So welcome to this afternoon session. We're going to be talking about dementia, which is one of the most common problems in older individuals, as well as a hugely financially impactful issue for the financial status of the American healthcare system, but more importantly, hugely impactful on patients and their families throughout the United States and the world. All right, so if anybody is interested, we have no financial interest in any of the activities or medications or any of the other things we'll be talking about. We do want to make sure that you get the credit due for you, so you have to complete the evaluation at the end in order to get the credit, which will be developed in conjunction with Metro and the Maryland Nurse Association and the American Nurse Credentialing Center. I'd like to start just to get a sense of where you folks are at, give you a couple of minutes just to see how you feel right now in terms of your competence and knowledge regarding patients and families and how to best assist them with dementia. And yes, we'll ask the same question at the end. So, are you getting responses, Terry?
I'm getting them. Yep. We'll give it another few seconds and then I'll end and launch the results.
All right. So most of you feel you have some knowledge. A couple of you feel like you've got a special amount of work to do, but basically nobody feels fully comfortable with that. And that's not surprising considering how fast this field is moving, how fast things are changing in terms of the care of dementia patients. There are new medications being developed. And all right, so we're going to talk about dementia. We're going to differentiate that from delirium. It's very important because delirium is a medical emergency until proven otherwise. And in the next two sessions, we'll cover in depth delirium and depression. We're going to talk about the aging population, and particularly the aging population and the impact of dementia. For the aging population, the way I just look at it basically is 10K a day, which is that 10,000 people in the United States every day become over the age of 65. So it's a growth industry. There's now far more people over the age of 65 than there are people under the age of 18. And the average American lives more than a third of their life as a senior. The causes of dementia are multiple. It's important, and we'll talk a little bit about differentiating true dementia, which is sort of Alzheimer's, multi-infarct dementia, some of the more unusual PICS dementias, versus the other dementia things, lookalikes, which include depression and delirium. We'll talk about strategies for managing the common health individuals that come up with older individuals, particularly those with dementia. But most importantly, talk about a holistic approach, including the medical, social, and emotional support needs of both the identified patient and the family, and how community health workers can support patients with dementia and be a critical part of the team that helps to manage these folks. As Darian pointed out, I would like to have this be as interactive as possible. So feel free to throw questions into the chat, raise your hand. Darian will try to help watch the screen because I'm trying to do the slides, which means I might miss something. But I'm happy to entertain questions at any time. Understanding dementia, the critical element to understand is that dementia is a very, very gradual process. The average person who has dementia has had the disease for about 4.5 years before they receive a diagnosis. And if you have dementia, the average person has the disease for approximately 15 years. The changes are chronic and occur over long periods of time. Differentiating from delirium, which is very acute, starts in a day to a week. So if you're working in an emergency room and somebody in the emergency room says, well, this person's just got dementia, and the family says, they were okay at Martin Luther King Day. It's like, no, you couldn't have been okay in the middle of January and be demented in the early part of March. All right. Disorientation occurs later, so that people who are demented months to years after start to become disoriented. Early on, it's much more mild changes. People who are truly delirious or confused, they get disoriented very early. They're not sure where they are, what time it is. Consciousness is basically in a demented patient, they're very clear. A delirious person, they're sort of out of it. The difference is sort of if you talk to somebody who's demented and you ask them the date, or you ask them, what's the name of their nurse, or whatever question you like to ask, they are aware that you are talking to them. They are aware that it is their turn to answer. They may not answer the question correctly, but they are in tune with the flow of the interview. In somebody who's delirious, you sort of get that sense, did they even know I asked a question? Did they even know I'm in the room? Do they even know what's going on? Psychomotor changes, which are really the sort of problems with your motor functions, are very late in the dementia stages, where you see people who basically get interesting things like what's called dressing apraxia. They can't figure out how the buttons fit together on their blouse or shirt. They can't figure out how to put things together. That happens earlier in a delirious person. Physiologic changes are far less prominent in dementia patients. They tend to have the common medical illnesses of old age, hypertension, diabetes, etc. But people who are delirious and acutely confused oftentimes are having, an infection or something else that makes them physiologically appear ill. Their vital signs are often abnormal. The sleep-wake cycle is one of the things that's most problematic for demented individuals. When somebody gets their sleep and days and nights mixed up, it's very, very challenging for their family. Classically, it's the sandwich generation, which is the daughter who is trying to manage both children and parents and a job. So they've got the triumvirate of stress. And if you take that and you suddenly have the elderly parent awake for 3 or 4 hours during the night, that makes it very hard to take care of your kids and very hard to be good at your job. It's important to realize that starting in, I think it was about 1998, they did a study and they saw that there are now, ever since then, so for the last 25 years, more days lost from work taking care of your elderly parent than there are days lost from work taking care of your children. So this is the big picture. All right. In the sleep-wake cycle, in the person who's confused, it's sort of like, well, hour to hour, they're there, they're not there, they're with you, they're not with you. Even in the course of one interview over half an hour, you might say, boy, they seemed totally on target, and then the next minute they were gone. Dementia tends to be stable day to day. It changes month to month, season to season. The easiest way to talk to somebody historically about dementia is, well, how were they at New Year's? How were they at Christmas? How were they at Thanksgiving? You know, people don't really keep track of days and weeks. They just sort of say, Mom was a lot better last year at this time. And that's much more helpful than sort of just asking, well, how were they yesterday? Dementia, by and large, is not reversible. There are some disease modifying treatments that are mildly effective at best. A delirium or an acute confusional state is usually reversible. If you can figure out whether that's from a medication, from an illness, from something else, figure out what the underlying problem is, fix the underlying problem, their confusion will improve. It may not improve right away. It may take, a day or two. It may take a month or two before their confusion totally clears. And it's important to sort of recall that it's not strictly an either or. You can be demented and have a subacute delirium on top of that. So say you've been demented for the last 7 or 8 years, you develop pneumonia, you're suddenly going to be dramatically worse than you were in the recent past. 5 million Americans have Alzheimer's disease. It's a huge amount of the population. Disproportionately higher rates among African Americans and Latinos. 70% of all the dementia patients are living with family members. 20% are living alone, which tells you the myth that people who get demented end up in skilled or nursing facilities is just that. It's a myth. That's less than 10% of the population. So the vast majority of this illness and the vast majority of this care for this illness is sitting right in the laps of the families who are having to deal with it and having to live through it. And that becomes one of the critical points where you folks are going to be able to really give them some support and some benefit. Because there's a lot of support out there, but it's not necessarily easy to find. It's not necessarily readily accessible. And sometimes it's just sort of getting them tied into whether it's the Alzheimer's Association or some other supportive Turk organization, many of which have virtual options, because it's oftentimes very hard for people because they can't go somewhere to go to a support group because they can't leave their elderly demented parent alone. Early detection is, there's a poll question before I give the answer. All right. Do you think that early detection is valuable because it's curable, holistic support, ultimate? Go ahead and answer the question. Darian will help me out. You're on mute, Darian.
Yep, so it's launched, so we'll give it about a minute or so. I see results trickling in, so.
I had to answer the poll and raise their flat hand instead. I've done that.
Here are the results.
All right. So yes, all dementia is not curable, and dementia is genetic in a few populations. Particularly people with Down syndrome may get true Alzheimer's disease in their late 30s, early 40s. People who get dementia in their early 50s, mid 50s, maybe even early 60s, potentially have a genetic component. Most of the folks, and it's most of the folks who have dementia in their 75, 80, 85 range, is usually not a genetic condition. All right, early diagnosis, biomarkers. So there are now biomarkers that are being used to identify dementia. Some of those have to be done by a lumbar puncture. Some of those can be done by blood tests. The issue is that they are not 100% reliable. Very few dementias like Huntington's dementia associated with Huntington's movement disorder is very, very genetic. And you can actually diagnose that with a genetic pattern. Most of them, you can say, well, there's a genetic tendency, but that doesn't necessarily help you. And the problem with the biomarkers is that we used to think that dementia was one thing. We now know that there's probably at least 5 or 6 different pathways to get to dementia. The apoprotein E, the acetylcholinesterase, a variety of other factors. So the biomarkers necessarily will only pick up 1 or 2 of those. One of the things that's interesting to consider is the ethical issues, which is if you are, say, 55 years old and you do biomarkers and the biomarker says that you have a high risk of developing dementia, and yet we don't have a known effective treatment, have we done that person any favor? Have we actually improved their life? Some would say yes, because you give them the ability to do planning, whether that's planning about living situation, planning about support, financial planning, other issues. Some would say no. They basically get an issue where, do you put the person at risk that they might decide, well, then I'm just going to commit suicide at age 65 because I don't want to live through it. And have you really improved that? And then on the other hand, we don't know that research is moving quickly to try to improve the treatments. There's now the monoclonal antibody treatments, which are, again, unfortunately, only minimally effective, but we're getting closer to actually being able to chip away at some of that. It's also very difficult oftentimes to differentiate an early dementia from what's been called minimal cognitive impairment, sometimes benign senescent forgetfulness, which is some of the things that can occur with sort of mild changes, but are not truly a full-blown dementia. A full-blown dementia, by definition, is a progressive degenerative decline in one or more realms of cognition. So that's having to miss, memory, visual, spatial, language, motor, whatever else. Minimal cognitive impairment tends to be fairly isolated, fairly local to memory issues. It's the classic, oh, I can't remember the name of that person who I met a year ago at this same church and I just can't come up with their name. That can be minimal cognitive impairment if there's no other evidence that there's other things going on in their world. So let's do another poll and keep you guys interested since you're all now finishing your lunch and about to take your mid-afternoon nap.
I'll give it another few seconds if you want to submit for the poll.
Thank you. Okay. So we did all figure out the younger is more likely to be genetic. Unfortunately, dementia is not rare. And dementia and delirium are two distinctly different problems. And true dementia is not a normal part of aging. So with normal aging, there is not full-blown dementia as an inherent cause of growing old. Recent developments, let's talk about the difference between normal aging and Alzheimer's. So normal aging retrieval deficit, which is what I just talked about, I can't come up with the name of that person. But if you give them clues, that'll help. Oh, you remember she's married to Harry. Or, oh, you remember she was the one who was at our wedding, or this or that. All right. With a true Alzheimer's disease, they truly have memory lapses, and cluing them does not help. In normal aging, people know they can't remember something, and it frustrates them. They're what we call the worried well. They're like, oh, doc, I must have dementia. I can't seem to come up with people's names. Insight in Alzheimer's disease is often lost. They don't really realize that they can't remember. The activities of daily living, which are basically, toileting, transfer, continence, dressing, bathing, feeding, those start to be affected in full-blown Alzheimer's disease. And that's what I mean, that it's much more than just a memory issue. In normal aging, those things are okay. You do things more slowly, but you can still do them. And even the independent ADLs, sort of think of the ADLs as what do you need to survive for 24 hours without somebody else's help? The IADLs are what do you need to survive for 7 days without somebody else? So that includes a little bit of managing your money, getting groceries, preparing a meal, using a telephone, those kind of things. Again, In normal aging, those things do not go away. In Alzheimer's patients, those things can go away, and they go away somewhat on the earlier side. There may be delays in word finding in normal aging where it takes you longer to get to the answer. In the true Alzheimer's patients, they actually can't get the answer. It's anomia. They just can't come up with it. There's a book called The Boston Naming Test, which actually takes words, 60 words from low frequency to high frequency to low frequency. And you can measure how well they do and how far along that they can get before they start to get into anomic and inability to catch on. The visual spatial, which is very important and very early as an early diagnostic tool in dementia, is really not present in normal aging. That's what you see when you see people doing clock draws. Clock draws basically assess a number of things. They have to be able to know their numbers. They have to be old enough they've actually seen a non-digital clock, which I'm not sure. There's certain of my children who I don't think have ever seen a non-digital clock. And then there's the issues around, can they put the numbers on and can they put them ahead and put them in the right spaces? So Joe Foley, who was one of the founders of one of the neurology folks here, basically said, if you look at us, if you put a circle down and you go, you're 12, you're 6, you're 3, and you're 9, you're almost by definition don't have Alzheimer's disease. Because you cognitively summarized by breaking the clock down into parts. You basically hit the visual spatial right off the top. You got the 4 corners in the right places. And so all that together means your visual spatial is essentially very well intact. The apathy, which is true in Alzheimer's disease, is sort of they're not upset about their loss. That's very much, as we said, sort of pathognomonic. Whereas the younger person really are very upset. And the Alzheimer's patients tend to sort of disengage from the world. It makes sense. If you're sitting at some party or trying to watch a television show, even a half an hour sitcom, if you can't remember to follow the story, you quickly lose interest. In normal aging, people stay socially engaged, they stay socially involved. And people say, well, social engagement prevents dementia. That's not, is that true? Maybe that helps. On the other hand, really what's happening is that the people who are demented are dropping off. So you got to be a little careful about what's the cause and effect there. We talked about the cost, $172 billion cost to the US in 2010. That's a hard number to get any sense of what does that mean. So if you take a Medicare patient, the average Medicare patient costs an insurance company $439 a month. The average patient, same age, same Medicare insurance with dementia is going to cost $1,262 per month. So 3 times higher cost. Medicaid, it's even more dramatic because Medicaid are younger people, so their baseline cost is different, but their baseline cost is high because of all the social determinants of health. But without dementia, $700. With dementia, nearly 10 times that amount. So we're talking about a huge financial burden as well as the family and social burden. Medicare admissions, patients without dementia are only getting admitted occasionally, 266 admits, versus people with dementia, 828 admits. So you're much more likely to end up in the hospital. Part of that is that the demented individual is unlikely to come to attention early on when things can be managed in an outpatient setting. They're not going to do well at presenting and identifying symptoms. They may not have good access to their physician or their nurse practitioner or their community health worker because they're stuck at home alone and people are not aware of exactly what's going on. So, another poll, I like the little question marks. Dementia care should include which of the following?
About another few seconds.
All right, you guys nailed it. Good for you. All right, yeah, there's a lot to this. There's a lot of family and social support. There's a medical treatment is actually in this one sort of at the smaller end. Planning for future housing and financial needs. This is really a sweet spot for a community health worker because there is so much wraparound need for what this person needs in order to do well with this disease. And it's not, it's not that the disease has to be catastrophic, and there can be quality of life in the early years. But it is about making sure that you're planning well for the future, you're planning well for what's going on, what's going to go on, and being able to give that person, and more importantly, that family, some real support. Treatment, the non pharmacologic family support, figuring out how to get their family to be supportive. It's interesting because the concept of the extended family has really been a myth in America. It's not a strong population for extended families living together, residing together. The only time that really was true was during the Great Depression, when people did it out of economic necessity. Some cultures, it's more likely to be true than others. But all the families feel some need for support. And it doesn't necessarily, it's interesting, it doesn't necessarily matter if they're having to do the hands on day to day caregiving. Sometimes the burden of feeling not supported for the family can even paradoxically be greater for the daughter or the son who lives out of town because they don't feel like they can control the situation. They don't feel like they can be helpful. They have no sense of agency. All right. Figuring out what's called the hierarchy of need. So essentially, Maslow's hierarchy, which you may or may not have heard of, but essentially, if somebody's irritated, agitated, whatever the word is, you start to look down and you ask yourselves, are they hungry? Are they in pain? Do they need to go to the bathroom? Are they angry? Are they frustrated? Walk down the list of what could be going on because they may not be able to tell you, I'm just hungry, but if you give them give them a cookie, give them whatever, they may suddenly relax. But sometimes, when people get very frustrated by trying to say, well, mom, tell me what's wrong. Tell me what you need. Tell me, that can become a frustrating cycle. And then once the frustration rises, the cycle rises, the anger rises, and you get into more challenging situations. Modifying the physical environment can be very useful. Putting somebody in a situation where they don't have access to open stairwells that they could fall down. They don't have access to get out of the door. So if they're going to wander, if you can restrict them so that they wander on one level in the home and not have access to getting to the outdoors or to the stairwells, wandering becomes far less concerning. They tend to just walk around, burn off some energy. There's a lot of things you can do in terms of deactivating the stove so that somebody can't start the gas, can't turn the stove on and get a burn. Basically it's not childproofing, it's somewhat different than that, but you can create an environment where someone can be safe because the environment is safe. There's always a safety freedom balance. Okay. You can make somebody 100% safe by chemically or physically restraining them. But if you chemically or physically restrain them, have you given them such a loss of quality of life that you really haven't gained anything in the great big picture? And we always see this when people say, well, I was so afraid she might fall that I put her in a nursing home. And, well, why'd you put her in a nursing home? I was afraid she would fall. Well, what's the worst thing that happened if she fall? Well, if she fell, she could break her hip. And if she broke her hip, what's the worst thing that could happen? Well, she'd end up in nursing. And you sort of say, well, you sort of went full circle there. You sort of gave her the worst consequence to prevent the fall. So you got to just be thoughtful that you're putting your plan together and doing your plan, working with the families. Pharmacologic treatments, the acetylcholinesterase inhibitors, that's your Exmon, your Ariceps. There's some benefit for about a year, some slowing of progression. But these are things where they talk about statistically significant differences. You really have to sort of see when people are put on these. First of all, give them realistic expectations. Second of all, do check-ins. The advantage for the community health workers, you guys tend to be able to be in touch often and frequently. And so 1 month, 3 months, 6 months, did that medicine help? And it's always important when you're dealing with any of that. Did that medicine make them better, worse, or no different? There may be some mild benefit in ADLs, some mild benefit in behaviors. It only really helps, even in the minimal effect that it does help, in 30% of people. Some delay in caregiving burden, some delay in nursing facility placement, but we're talking maybe 3 months over the course of the 15 years. It's useful in mild to moderate. NMDA is like your Namenda kind of thing. That's used for people who are in the stages where they're later on, they're already been on an A receptor. Oftentimes not a lot of additional benefit. Mixed results on ginkgo, vitamin E, I'm not going to try to say that, but not really any dramatics. Ineffective vitamin C, hormone replacements, NSAIDs, lecithin, carnitine, melatonin, B12, B6. Be a little careful because B12, if somebody has cognitive impairment, you do check their B12 level. If their B12 is low, you can give them B12 and their B12 replacement, their cognitive function may well improve. That means they did not have dementia. They had one of those dementia lookalikes. And so that's why they say it's ineffective to treat true dementia, but it's not ineffective for improving cognition in somebody who has memory issues or other issues because they have B12 deficiency. All right, let's see how I'm doing on time. Pretty good. So we've got about 15 minutes for the case presentation. And then I think there's about 5 minutes of cleanup at the end that Darian will do, making sure that everybody's getting the credit they need and everything else. And I do want you guys to participate. I know it's a little challenging when you're sort of on a big screen like this. So Mr. Matthews, 76 years old, mild to moderate Alzheimer's disease, diagnosed about 2 years ago, high blood pressure, diabetes, lives with his daughter, who's his primary caregiver. A former teacher, enjoys music and gardening, but has withdrawn from those activities over the past year. At the first encounter with the community health worker, is introduced to both the patient and his daughter Lisa during a home visit. Home visits are hugely beneficial. You can learn so much and you can gain such a growth in the relationship. Lisa reports that her father has been experiencing increased confusion, difficulty remembering recent events, and occasional agitation in the evening. She feels very overwhelmed as a caregiver and is unsure how to support him. So, why don't we try to discuss these sort of one at a time? What could you do to build rapport and assess the patient? I'm a patient fellow. I can wait for somebody to answer it.
And then we have a chat, listen to the patient's needs and wants.
Yeah.
First, thank them for even sitting down for the meeting in the first place. Because once you acknowledge that part, that generally tends to open up the engagement for the conversation.
You both have hit two critical elements, engaging, and please remember, engage with the patient first. Even though you want to immediately talk to the daughter, always talk to the patient first because they know that you're supposed to. And at some emotional level, they'll be notice if you don't, and they might get agitated. But I agree, just acknowledging and thanking them for allowing you to be part of their care team and allowing you to be in their home is going to really open the floodgates. What other ideas do people have?
I can read some from the chat. Active listening and showing interest. Let the daughter know that you understand her concerns and provide her with resources. Ask them questions about themselves and the family. Gather more info. Build trust. Ask open-ended questions. Listen to the client and his daughter and have a home visit.
Ask the daughter, like, no. Ask the client some of their likes and dislikes, and then maybe engage with the daughter to say what's happening already. How can I support you in what's already happening?
Absolutely. I mean, those are all great suggestions. And thematically, also making sure that you're giving them messages of hope, that there is and are things we can do to make this better. And you have to be realistic. You have to sort of say, even if we can't change the memory, we can help your life be more manageable. And I love the thing about figuring out what that person liked or needed, what are that person's life choices, and all of the active listening stuff is huge. The problem is oftentimes the daughter is hugely isolated and just feeling like someone out there is listening, someone out there cares. Anything else from the chat, Darian?
Yep, provide support resources for the daughter, engage the client in conversation about teaching career, ask the client his concerns and needs, make a goal list.
All excellent suggestions, and that really helps us move to the second question, which is what education might you provide for the patient and his daughter?
I'd educate the daughter that to encourage him to keep doing for himself, no matter how long it takes. They need step-by-step direction. It's better to keep them active than for you to do it for them just to get it done.
Very true. And then the concept of if it's not working, you walk away, come back in 10 minutes and try again. Don't get into battles. What about supports that are out there? What supports could you offer them?
One of the things I put in the chat is to, have the daughter and the client make an appointment with their primary care physician to, maybe rule out if there's any kind of organic issues going on with him. And then we can start looking at like resources for memory loss and things of that nature.
That is a critical and essential element. As we talked about, making sure it's not one of the dementia-like illnesses or, God forbid, a delirium. So that's a beautiful answer. What sort of supports are out there that we can give to the patients?
So we have healthy eating or inshores.
I mean, one of the things I try to start first with is sort of how have they managed other crises in their life and get a sense of what's their learning style. Okay. Some people say, well, I read about it. Okay. If you read about it, I mean, the classic book out there is called The 36-Hour Day, which is really a description of taking care of an Alzheimer's patient, which people look at that and they read it and they say, oh my God, I'm not alone. Okay. And you can get that off of Amazon. There's so many copies out there, you could probably get it for $1.25. Or on library and Libby app, or get the library, whatever, for free. In addition, the Alzheimer's Association, which exists in everywhere, you can call them and they will do telephonic support, whether that's support group or one-on-one support. They will be able to offer resources, and that's a critical piece. What could you do to promote safety and wellness?
Alzheimer's support groups for the daughter.
Correct?
Develop a plan to safeguard patient's environment, create safe environment at home, remove any harmful items from the home or out of his reach, exit seeking behaviors, fall risks,
How can you prevent an exit-seeking behavior?
You can't.
You can't necessarily stop the behavior, but you might be able to stop the exit. So they do make the pseudo doorknob so that if they actually use the doorknob, it spins, but the latch does not undo. So the door actually won't open. It's sort of almost a child-proof lock. You have to squeeze it a certain way in order to grab the knob and have the knob actually turn. So there's some things like that, turning off the burners on the stove, which now some you can do just automatically. Some you have to get behind them and actually shut off the gas. The one that I always make sure we emphasize is what used to be called the TOPS, which is time off promotes strength, which is make sure they have some respite, some way to take a break. Okay. And that's oftentimes where you have to try to figure out, well, who else is around? Do you have any siblings? Do you have support from your church? Do you have support from whatever else it is? Even sort of, employee assistance programs now have opportunities for support. Even if you can figure out how to give that person an hour a day, twice a week, where they basically just get to relax and not have to be in the midst. Otherwise, not only is the burnout and the stress going to be huge, the risk for elder abuse goes up. What other thoughts do people have about safety and wellness?
We have locks up high, wander guard system that will alarm, proper lightings and grab bar.
A lot of things like avoiding throw rugs, avoiding, Cleveland is famous for having one outlet per room, so you have a lot of extension cords, a lot of falls risk things that you can try to really work on. Yeah, the alarm systems are good. They're a bit of a challenge because you have to be there in the room because they sort of tell you the person's gotten up, and unless you're really quick, it's hard to get there in time. I do know a number of people who've used the nursery monitor systems and been able to sort of keep an eye on their parents at a distance. I heard go ahead.
Create a distraction to the exit so they aren't compelled to open the door in the first place.
Yeah. Yeah, Maggie Calkins is one of the people became a world expert at sort of doing that, sort of obscuring the doorway so that the person would go somewhere else and not go out the door. All right. Thoughts on addressing caregiver stress?
I think there has to be more focus on letting the caregiver know that it's okay to take a day away or take, like I cared for my mom for 6 years and worked full time in my home at the same time. And my brother would offer and he'd show up, but I just didn't think anyone could do it as good as I could. And I felt guilty leaving. And I wish I had someone, because by the 6th year, I was ready to kill myself. But that just understood that I wasn't giving myself that permission. So I think from the very beginning, you have to give this caregiver permission to walk away, give the duties to somebody else.
I really appreciate your sharing that because that is such a classic story. They, and I'm not picking on the daughters, but it unfortunately falls to the eldest daughter often, or the in-town daughter. And they do feel like, I can make this work, but I'm not sure anybody else can make it work. My brother is he's just not the same. He just doesn't, he's not gonna watch her closely enough. She's not gonna feel comfortable with him helping her to and from the bathroom, whatever else it is, and really emphasizing to them that sort of long term, as you said, you did it for 6 years. In order to be able to do that long term, you're going to have some way to recharge your batteries. All right. I also talk a lot about making sure that the caregiver is getting what they need from a healthcare standpoint. When we designed our office, we designed it so that the waiting room was limited exit so that when the person came in with their demented spouse and you were seeing the non-demented individual, the demented spouse could be in the waiting room safely and not wander away. Because otherwise you get these people who, I'm not picking on Anna, but, if you don't get your blood pressure and your diabetes, evaluated for 6 or 10 years, that's going to have a cost. Okay. And making sure they have somebody they can talk to, somebody to dehiss with. Okay. The other thing is also there's another paradox here that we have to discuss, which is that caregiver burden is not a universal negative. When somebody comes in and they describe to you, or you're in their home and they're describing to you, oh my gosh, I have to do so much for my mom. I have to take this, I have to do this, I have to do this, I have to do this. You can say, oh, that's so hard, that's awful. Or you can say, wow, you are doing a great job. You have done so much. Okay. And there's a lot of role definition, there's a lot of pride. I took care of my mom. I really watched over her. I allowed her to have a reasonable life, even though she was demented. So don't forget that sort of, somebody describing how much care they gave could mean somebody who just needs somebody to say, good job. Thank you very much. And lastly, we got a couple minutes left. What kind of things could you do to help Lisa coordinate the care of her and her father? We did have one person already mention making sure that they're getting into their primary care.
Health referrals.
Health referrals for sure. And sometimes you have to be a little careful. The average primary care is usually great. There are times where, somebody will go to the doctor and say, it's okay. It's just normal old people stuff. If you hear that, you sort of say, I think you should advocate for that person to get a second opinion by, either a geriatric doctor who specializes in old people or a neurologist who specializes in dementia, or just a different primary care who's more up to speed about old people and dementia.
Other chats, make referral to area agency on aging.
Great idea.
Help schedule appointments. Medicaid insurance case manager, check to see if they're affiliated with any churches that offer any assistance.
Wonderful solution. The Access Your Benefits program, which is run through the area agency, but is available at some local hospitals, what can maybe give them, benefit on their home energy assistance, benefit on, a lot of the financial stuff, because it becomes a huge financial burden for the family as well. But those are great suggestions.
I would also say let her know that to keep the lines of communication open, and no question is a dumb question. Because a lot of caregivers will not ask because they feel like it's a dumb question. No question is a dumb question.
That is beautifully said. That is beautifully said. Signs of burnout strategies. We've talked a little bit about strategies. Anything you could sort of quick identify as signs of burnout? Oftentimes it is just empathic listening, hearing how frustrated or angry they appear to sound. That's sort of the early burnout, is they're just like, I can't do this anymore. I'm just so frustrated. And communicating with the older demented individual we talked about, going through the hierarchy of need. Being culturally sensitive is always critical. All families deal with this differently between cultures and within cultures, and expectations differ. Sometimes people also get trapped in a cultural expectation that they have to do X or they have to do Y. All right. Any other closing thoughts on how to advocate for comprehensive care and support? I know I sort of skipped through this last slide a little too quick, but
I think another thing is when you are a caregiver, I had a lot of problem with this. Make it clear what your schedule is, because, my mom was a naughty girl. But we did have a routine where she would lay down and nap at the same time every day. And that was just a breather for me. And it never failed. She would get a visitor who would come in. And if I'd say, well, she's napping, they'd go in her room, Allie, and wake her up. You have to keep a schedule that the caregiver can, like it was my time to just breathe, but nobody.
well,
I was, you have to get people to understand, like, this is the time, please don't come here. People don't listen all the time.
oh yeah. I mean, and that helped you, but that also helped your mother.
Oh, it did.
Having a regular schedule that she can sort of, she probably couldn't tell you what it was, but she feels comfortable because it's the same. Okay,
Yeah.
so having other people interrupt that is, yeah, we always would say, the out of town son who comes in and suddenly starts to do everything differently is not helpful.
Yeah, no.
All right. So one last quick poll, sort of, and I don't have the results of the first one in my head, Darian, but maybe you do. So how are you feeling now about how well prepared you are?
I respect everyone's time, so I'm just gonna give it another second.
All right, so we got at least the bottom end is picking up. That looks a little better to me.
Yeah.
All right, I hope this has been helpful.